Well, welcome everybody. Happy July 5th, and thank you actually for joining. Over here, it's like everybody's on vacation mode already, so I very much appreciate that you are joining us today. And for anybody who missed this, that's listening to the recording, thank you for caring enough to download and listen to a recording. Um, as you heard, and thank you for that introduction. My name is David Sinimo, and I have no disclosures, no financial conflicts. I do practice at the Lattimore TB clinic, where I see children and adults who are being treated for tuberculosis, both active tuberculosis and LTBI. My background is I did a mid-peds residency and then adult and pediatric ID fellowships. So today we're talking about pediatric latent TB infection. Um, and I am a federal employee. This is not a VA sponsored event. The federal government hasn't reviewed these slides, but you'll see that these are heavily utilizing both the CDC guidance and the American Academy of Pediatrics, of which I'm also a member. And then the most important thing to remember from this, from an epidemiologic standpoint, is that new TB infections in a child, whether that is a PPD conversion, the new diagnosis of latent TB, which is what we're talking about, or a child actively sick with tuberculosis, are a sentinel health event. Because we're not expecting to see transmissions. And you know that if you have a 1 year old, for instance, that's sick, well, they've only had a year that they could have been exposed and infected with tuberculosis. So your window of opportunity to get that contact tracing is really much more narrow, as opposed to a 70-year-old who has reactivation tuberculosis. When did they get it initially in the last 70 years? This is what I'm hoping to talk about today in the outline. And from what I've been told, you've had talk already about the adult diagnosis and treatment of latent TB. So, everything in pediatrics, one of the first things we learn in pediatrics residency is children are not little adults. And that is true. That is very, very true. However, there are a lot of similarities. So I'm going to focus on the differences, but also remind you of some of the similarities. I cannot see the chat box, but if anybody has questions, you can put that in there. We'll hit them at the end. But feel free, unmute, ask, interrupt. It's fine. We have plenty of time. Just so we're all on the same page, I personally hate the term TB exposure because it's pretty much meaningless. I, okay, so you were exposed. What does that really mean? You were around somebody that had tuberculosis. I think many of us have been. We just don't know. We're talking about TB infection, and I am old school, so I will keep saying LTBI for latent TB infection, but really TB infection is preferred. And by definition, these people are asymptomatic. They are not actively sick, but they can become sick later. How do we determine this? Well, they should be either TST or IGRA positive. And as part of my counseling for families, when I explain that, I say these are tests that look at your body's immune system. And this test is asking your immune system, have you ever seen this germ before? And a positive result just means the body has seen this germ before and has made an immune reaction to it. How is that going to happen? Tuberculosis germs get into your body, they're recognized by your immune system. T cells find them and develop specific reactions to fight those germs. That's all that test is telling you. It's not telling you sick, not sick. Unfortunately, we know that some people, while they can fight the germs well and they don't get ill, they don't kill all of the germs. And that's when we talk about reactivation TB. And this is part of how I counsel all of my families, because I need them to understand why I'm going to ask them to give their well child medication to prevent future illness. And that's what we'll talk about in a few slides. They're asymptomatic, so their physical exam should be normal, and their chest X-ray, which we'll talk about in a few, should be normal or just have a calcification consistent with past TB infection. We're not talking about TB disease right now, but I strongly suggest that you tune back in a few weeks when that comes up. The obligatory epidemiology slides. We're doing well with tuberculosis, but notice we're leveling off. Now, these are cases, not LTBI, but if you think about it, cases are a harbinger of infections. And so we're doing well, but again, we're not really dropping recently. And then we all know that COVID disrupted a lot of the public health infrastructure, and so we are seeing a bit of a rebound. Children are not spared. Children are not heavily affected by tuberculosis, but they are by no means spared. And about 4.4% of TB cases in 2022 were children less than 15. And in this age group, which I'll talk about when we talk about window prophylaxis, the 0 to 4, tuberculosis disease can be especially devastating. This is still an infection disproportionately burdening our immigrant population. So non-US born is almost 3/4 of the patients. But by no means would I use this epidemiology to try to single out any one group. We have much better risk factor based testing. I live in New Jersey, and so New Jersey is a hotspot. These are the latest CDC data from 2022. And if depending on which state you're hailing from, this is more or less interesting for you. For New Jersey, I mean, these are a little bit dated, 2020, but our counties, if you know New Jersey, this is the urban to more densely packed suburban. It is also the area that has the highest percentage of recent immigrants. So the epidemiology bears out again and again. And when you think about latent tuberculosis infection, all comers, 13 million people was the latest estimate from CDC living with LTBI in the United States. Now that's not just children, that's everybody. But 13 million. And why do we really care about this? If you look back in the literature 20, 30 years ago, especially in the developing nations in sub-Saharan Africa and Southeast Asia, nobody cared about LTBI. Everybody's health infrastructure was so much more focused on active tuberculosis. And that makes sense, right? Because the active tuberculosis with the ongoing bacterial replication, the positive smears, that's your route of infection. But we know that the conversion of latent TB back to active, the reactivation TB, if you will, is about 80% of the US cases. So until we get the LTBI treated, we're never going to get that number to drop further. So when we talk about reactivation TB, we have to think about numbers. And the numbers of the risk of reactivation TB really are predicated on the individual's risk factors. So that's age, and you'll see here the risk of reactivation or the risk of reactivation TB in adults is quoted to be 5 to 10% of a lifetime risk. And 50% of that risk is in the first 2 years. But what if that adult is living with HIV? And uncontrolled HIV for this example, well, then that risk is 5 to 10% per year. What if they develop end-stage renal disease and need dialysis, cancer and need chemotherapy? Or one of my favorite counseling points now is, what if they wind up needing one of those new medications? And I ask families, how often are you watching TV and you hear an ad for a drug? And then somewhere as they're talking, they say, Tell your doctor if you've ever been diagnosed with tuberculosis or if you've ever been around someone with tuberculosis, because immune modulation is really on the vanguard of medicine at this point. And I don't know if you will wind up needing one of those drugs 10, 20 years from now and increase your risk of reactivation tuberculosis. So, children, we do worry about reactivation tuberculosis, but we also worry about primary disease. And I'm going to talk about infants, as I said, in a few slides. But the risk, especially the younger you are, is that your body, your immune system, is not equipped to deal with this bacterium. And so you'd never get to latent tuberculosis because you become ill. And you can become ill with advanced pulmonary disease. You can become ill with disseminated disease. You can become ill with CNS tuberculosis, which is a particular nightmare. And so we are worried about that. And that's what leads us to the concept of window prophylaxis that I'm teasing now, but is the most important part of the distinction between adult and pediatric LTBI. So how are we going to diagnose LTBI in children? Well, these are the rules, right? They'll be testing positive. They will have no signs or symptoms of active disease, and they'll have a negative chest X-ray. So what about testing? So testing now is still either the TST, tuberculin skin test, or PPD, or a blood draw for an interferon gamma release assay, either the quantiferon gold or the T-spot. Those are just two brand names, and they're slightly different tests. So old school tuberculin skin test, that's what I had going to school, um, is falling out of favor. And the reason it's falling out of favor is it's tough. It's tough to do because you need to do it and you need to do it well. And I have to tell you, there's not a lot of people anymore who are great at getting a good wheel from that injection. And then you have to depend on the family or the individual to come back in 48 to 72 hours for a reading. And as people have become less adept at reading these PPDs, although we're still, I think, pretty good at it, the concern is the accuracy of the test. The other concern that everybody will quote to you is, but what about BCG vaccine? So for the purposes of public health, we ignore BCG vaccine. And that is actually, I think, correct. Because if you look at worldwide data, only about 50% of children who get BCG at day of life 1, which is the standard around most of the world, still have a positive TB skin test at a year old. So the idea that this skin test is going to last for decades is unlikely, but we have data that it does happen. And so we know that BCG is a recognized false positive TST. The other thing is, the size of the reaction. It is highly unlikely that you're going to get more than 15 millimeters of induration from a BCG vaccine. But again, these questions are raised. How do we get away from these questions? We use an IGRA. So the interferon gamma release assays are blood tests that take lymphocytes, specifically T cells, and they put them in contact with two very specific antigens found only on Mycobacterium tuberculosis and not on the BCG strain that is used in the vaccine. So there is no cross reactivity, 100% certain of that, and that's a big counseling point. The negatives for the interferon gamma release assays are there are limited data, less than 2 years old, but data are actually coming and they look pretty good. So when this first started, we said we don't use IGRAs less than 5, and then it was less than 3, and now it's less than 2, and we're learning that they are still fairly accurate. So there's more acceptance, but the guidelines haven't changed yet. So 2 years old is still the cutoff. And the other issue is the interpretation, and people get annoyed with the indeterminate reading. And if you've been sending these tests, you've probably gotten back an indeterminate reading. And yes, that's annoying. But the thing that I always say when I get a call to do a consult about a patient that has a indeterminate interferon gamma release assay is, great, we know the test didn't work. So this test looks at two different tuberculosis antigens, but it also has a positive and negative control. And reasons for indeterminate are the positive control fails, especially this is my patients who are living with advanced HIV. They don't have enough T cells to make a positive reaction to anything. Or the people who have, really twitchy, tickly immune cells and they react to everything and their negative control failed. But what I always tell people who are lamenting this is the TST doesn't have a positive and negative control. So you did this blood test and you have an indeterminate result because it didn't work. But if you think about it, if you had done a TST, you would have a result, you would be believing it, but you really don't know if that test worked or not. And so I don't really get bothered by the indeterminate. What I usually do is wait a few months and repeat it. Now, if we are going to do testing, we really want to do targeted testing for the kids who are at highest risk of getting tuberculosis and those at highest risk of progressing to becoming sick if they were to acquire the infection. So who's that? Well, children who are close contacts of people with tuberculosis, suggestive or concerning clinical findings or radiographic findings, and really people immigrating or having traveled to a country that has a lot of tuberculosis going around, right? That's your target. And if you're talking about travel, you're thinking about travel, remember that it takes between 8 and 10 weeks to develop a robust enough cellular immune response to give you a positive TST or IGRA. And that 6 to 8 weeks is going to keep coming up. This is a great, and if you have a copy of these slides, all of these links are active and will work for you. I really like this. This is a great risk assessment questionnaire. I think this is something that pediatricians' offices can use, and it really helps you, really focus in on the children who most need testing. Because some of us are still using PPD out in the office setting, it's important to recognize what is a positive test. And this is a great example. I actually use it as a teaching example for medical students of sliding your positive criteria based on the sensitivity and specificity and the idea that you want to open up your net to catch the most real positive cases. So what does that mean? So if we go through this and we say, well, 15 millimeters of induration or greater. So that is for kids who have no risk factors. Now, the reason there's a red X next to that, my question is, why did you even test them? But if they have really no risk factors, then you're really thinking that this test is probably not a true positive. So you want the most robust positive possible before you have to consider it. Compare that to kids with a lot of risk factors. Kids we're really worried about, those in close contact, those that we already are worried about having tuberculosis disease because they're having clinical evidence, or the immunosuppressed or living with HIV that might not be able to make the best or most robust reaction. There, they only need 5 millimeters of induration. Now, I have a little problem with this line right here because we know that tuberculosis infection in and of itself is immunosuppressive. Hopefully you've heard the term a paradoxical reaction. Basically, being sick with tuberculosis makes you immunosuppressed. So in my teaching, the way I was taught and the way I teach others, is if you believe someone is actively ill with tuberculosis, there is no negative skin test or IGRA that can drop that belief from you. Because we know that up to 50% of people that are presenting to the hospital with culture positive cavitary pulmonary disease, for instance, have negative testing. So even at 5 millimeters, I would say if you believe this, you have to go through your workup. And then the in between is the 10 millimeters or greater. So these are kids with high risk conditions, but not high, children born in high prevalence regions. And the one I always point out is anyone younger than 4 years old, because it takes a while for your immune system to really grow into those robust responses. So really, which one is better? You have to decide that for yourself. The sensitivity specificity data are pretty good for both of them. They're not perfect for either of them. And I would always say it's based on what your patient population is and what your patient population needs. So then let's say we have a positive test. How are we going to evaluate and how are we going to treat? So it's back to these rules. How do we diagnose LTBI? Well, we just said we have a positive test. We're going to do a good physical exam, a good history, and we're going to get a chest x-ray. So the chest x-ray really needs to be reviewed by somebody who's skilled and comfortable calling it normal. So in my world, that's a pediatric radiologist. I hope in your world that's the same thing. And we're looking for clear normal chest x-rays or, a calcification, because that's your GON complex. So this is still negative in that it does not have to be consistent, or it is not consistent with active tuberculosis, but it is highly suggestive of a past TB infection that got calcified and walled off. And then your signs and symptoms is really a thorough H&P. And please remember, everything we are talking about, chest x-ray, lungs, chest x-ray, is very important because of the public health implications. Pulmonary and laryngeal TB are basically the way tuberculosis is spread person to person. That's the contagion. But lymph node TB, GI TB, GU TB, musculoskeletal and osteomyelitis, are all possible. And so my thorough exam isn't just listening to the lungs. It's, are there any bone pains, joint swelling? Is it a normal abdominal exam? Are there any abnormally enlarged lymph nodes? And certainly if there's any symptoms, that can really drive more testing, because you don't want to miss active disease and inadvertently undertreat it with LTBI treatment and engender the risk of resistance. Um, these are older kids, admittedly, chest X-rays, but it's just a pointing out that the X-ray that could be TB disease. Now, none of these are LTBI. All of these should be started on for drug therapy and not LTBI therapy. But we've got a miliary pattern, we've got significant adenopathy. I often joke I could show the same X-ray and say that it's sarcoid. And then the adult type, right upper lobe with a cavity. We really can see anything. Adenopathy, I think, is in some ways more seen in children, because I think we have better chest x-rays, frankly, for children. And, this is a kid who had primary pulmonary tuberculosis, but really it was right-sided hilar adenopathy as the main finding. And this is just severe adenopathy, and an advertisement for the lateral chest x-ray. So there's a lot of controversy. Do you need lateral chest x-rays? For young children, we really do mandate them. I personally believe everyone should have a PA and lateral chest X-ray because of the findings of adenopathy being so suggestive. And then sometimes you have an abnormal chest X-ray, but it doesn't suggest TB. So this is a 2-year-old that is afebrile and wheezing on exam and is blowing snot bubbles with a runny nose. And this is a very typical X-ray for a viral bronchiolitis. They're hyperinflated. They've got some peribronchial thickening and cuffing. No significant adenopathy. So, so what do we do here? Because this is not a negative chest X-ray, but this is not what I would expect for active tuberculosis. So I often think back and remember, though at 2 years old we could argue this if they have a known exposure, but LTBI treatment is often not an emergency. There's a couple times it is, and that's because it's high risk exposure, but most times it's not. So if I'm especially if I'm dealing with an older child who looks well and I think has a cold, I can wait a couple weeks and let them get over that cold and repeat the chest x-ray if I'm concerned rather than racing down a treatment that could be wrong. When we're doing that, the physical exam, we're also doing a symptom screen, and these are the questions of the symptom screen. These also come up in my world after I'm done treating LTBI because I tell every parent and the older kids, you have been treated. Your test will remain positive for life. We do not currently have a testing algorithm that can show us successful treatment of LTBI. It is what it is. You should never get another tuberculosis test. What you should do is periodically be screened for us with a symptom screening, which is this. If your symptom screening is positive, you should get a physical exam and a chest x-ray. You should not submit to yearly chest x-rays because you will glow in the dark before we find anything. And I know that this is something that they're probably forgetting, but I just hope that they remember it enough. If somebody does another test, they say, wait, 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 no, I was treated and here are my records. So we were talking about high risk, and really one of the highest risks is the person who is a known contact of a person with infectious tuberculosis. So we are worried because these patients have potentially recently acquired infection and could progress directly to primary tuberculosis without developing a latency. Who are we worried about? We're worried about our young children, less than 5 years old, and the risk is directly related to age. So less than 1 is much more dangerous than less than 5. And you know these things if you've talked about adult TB exposure and infection because it's very, very similar to patients living with HIV who also can be treated with exposure. So, because we are worried in our young children that they can get sick very, very quickly, we need to rapidly evaluate them and make sure that they do not have active TB already. We're not already too late and they're already sick. And if they are not, if they are still well, we preemptively start them on LTBI treatment, presuming they might have been infected. This very much goes back to the 8 to 10 weeks. So if you could imagine trying to explain window prophylaxis to a parent, it goes like this. Your 2-year-old looks great now. Okay. They're running around, active, playful, eating, totally normal. Their physical exam is perfect. We have a chest x-ray. There's no evidence that they have tuberculosis pneumonia anywhere in the lungs. But we don't know that they were not infected yesterday because the person who they were exposed to went to the hospital yesterday, and here we are today. So we will do a test. We'll do the blood test, we'll do the PPD, but we can't trust that. If it's positive, we know they've been infected. But it is negative, we don't know if that infection happened yesterday, and it will take 8 to 10 weeks for that test to turn positive. We can't wait 8 to 10 weeks because they can get sick in the meantime. So we're going to offer you some prophylactic treatment. And so the prophylactic treatment is really the initiation of LTBI treatment. So great QR code for additional resources. Um, Here are our three recommended LTBI treatments. Um, my disclosure to you is I use a disproportionate amount of rifampin daily for 4 months, 120 doses. This is generally my go-to, except for a few different places where I will tell you why. Um, 3HP has very good success, very good adult data, um, really good data over 2 years old. The problem that I personally have found with this regimen is the pill burden, but it really depends on the child, how good they are with taking medicines or not. It is something certainly to keep in your armamentarium. When I was coming up training, we were always doing 9 months of INH. Um, that is still there, it's acceptable. The reason that has fallen out of favor is getting anyone to do anything every day for 9 months is very difficult. It's a pill burden issue. So this is in all of our clinics. This is our go-to. The newest one is the 3HP. It's the weekly isoniazid rifapentine. Um, this is my big con. Now, admittedly, this is the full adult dosing. Um, I don't know that I could take 10 pills, every Monday morning as a handful. Um, I also, because it's how my brain works, it's much easier for me to remember to take something once a day than once a week. And so, although it is not still demanded in the guidelines, I do prefer that we use some mode of directly observed therapy, even if it's the IMOCA with this regimen, because I just think it's very difficult for people to remember to do something once a week. The efficacy data, and these are efficacy data that originally came from adults and then were recapitulated in children. It works great. I think you've seen this already. It works great. Um, the completion rates are higher, basically because shorter is almost always better. And there was actually fewer adverse events, which is impressive because these are high doses of medications. But what we've noticed is a lot of the hepatotoxicity evolves over time, especially in adults. It's not recommended less than 2, and if you have presumed resistance. So this is, something that is we'll talk about when we talk about working up using data from source cases. But we also have to think about resistance. So just some tips on how to really do some of the counseling and the parent or caregiver education. One, you really do need the translator phone on this one. If you're not fluent in the language, because there should be a lot of questions coming from the families. Um, and so I immediately walk in, translator. I review the reasons for the treatment, and I try to talk about this is what's going on right now. And a lot of times I'm also allaying fears. She's not sick right now. She's not contagious right now, but there are these potential future risks. And then there's also just, making your life easier. So, every school is going to talk about TB testing. And what I say is, now we've tested positive, and every school is going to ask you about treatment, treatment, treatment. Let's just treat now for LTBI, and you're going to get a letter at the end of this that says that you completed this treatment, and you're going to put it with the shot card and the birth certificate. And every time somebody asks you, you're going to pull out that letter and say, no, no, we took care of this already. Because remember, that TB test is staying positive for life. And then we talk about medications. We talk about medications and possible side effects. So in children, the side effect of liver toxicity is vanishingly rare, 1 in a million. Um, Children haven't abused their livers the way we adults have. They don't have other medications. They don't usually have fatty liver yet. But we do talk about liver toxicity for both INH and rifampin. And we have to talk about these are the signs. If you're seeing decreased activity, decreased appetite, belly pain, vomiting, yellowing of the skin or eyes, you stop the medication immediately and you call us and we will see you. Because we also know that hepatotoxicity is worse over time. And the people who get into real trouble with hepatotoxicity are the ones who continue their medications after symptoms begin. Everybody on rifampin gets warned about orange secretions because it's not hematuria, and I don't want them worrying about that. And everyone gets a talk about drug interactions. And everyone of potentially childbearing age, even when they say they have no medications, I directly tell them that oral contraceptives can be inactivated by rifampin because of the drug-drug interaction. The reason I do this is because I think it lets the families truly engage in shared decision making of what we're going to give. Are we going to give rifampin versus isoniazid versus the 3-HP regimen? What's going to work better in your family's life? But then remember, Google still exists. So even if you think, as I do, that the risk of hepatotoxicity is vanishingly rare, if they go home and Google any of these drugs, that's the first 10 things that are going to come out. And I really want them to hear it from me first before they find out on the internet and really can't do a proper risk assessment. Pyridoxine is rarely needed in children if they are eating a full balanced diet. Um, for patients living with HIV, we do use it. Anybody pregnant, we use it. And exclusively breastfed infants, definitely, because there's not enough in breast milk. But I usually ask a quick diet history. It's not a thing that's difficult to give. It's not a thing that really will have a lot of side effects. But if you can get away without having to give pyridoxine, it lowers your pill burden. I strongly suggest everybody has something like this. CDC makes great handouts so that they have something that they're going home with, because they might not have all of the questions when you're talking to them. For treatment adherence, this is where our nurses are amazing. Um, they're watching the Emoca videos for the patients on Emoca, and we have any child less than 5 on Emoca. We also, have the ability to kind of almost like do a quick little physical on those videos. As far as using the medications, we only use tablets or capsules. We do not do suspensions. The suspensions are notoriously, one, bad tasting, but also very variable in how well they're made and how well they last. For isoniazid, you can crush it, and you can see those pictures right there. For rifampin, you can open the capsule, and then we tell the families, mix this with a little amount of a food that they like. And isoniazid tends to be pretty bitter, so things like chocolate syrup cover that better. Rifampin doesn't taste that bad actually, but a problem or a mistake that's often made is if you put it in a full bottle, for instance, if the child doesn't drink that entire full bottle, they didn't get the full dose. So it's much better to mix it with just, let's say, a tablespoon of food, and then you know that the full dose got in, and then you can finish the rest of the food. So, so I've alluded to window prophylaxis and where PEDS is different. So these are actually, old data, and the next couple slides are actually just very old data. But because luckily we don't have so many infants and young children with active tuberculosis now, we don't get to make these great data sets. But if you look at this chart, we have age and then the risk of disease following primary infection. So this is do not stop at latent, go directly to primary disease sick. Disseminated TB or TB meningitis, lung disease, no disease. So 50 to 60% are sick if they contract tuberculosis less than a year old. 10 to 20% with meningitis or disseminated, 30 to 40% with pulmonary TB. This is really, really bad. Okay. And this is our highest risk. High rates of morbidity, mortality, high risk. If you look at the first 2 years, this is really our risk of TB meningitis. Because of this, we can justify empirically starting window prophylaxis until we know more. These are data from Stark's textbook, and I just want to point out these are data from the pre-antibiotic era. Hypersensitivity is PPD, skin hypersensitivity. So remember, 8 to 10 weeks, so 2 months. So before your PPD turns positive, you already have a significant risk of having developed miliary or meningeal TB, bronchial perforation. This is prophylaxis. And so if we think about, this is infection day 0, we have to wait and do repeated testing in order to get a positive test. In the meantime, we are treating. So children older than 5 basically are like adults if they've been exposed. We're still evaluating them to make sure they're not sick now. You do a TST or IGRA. If it's negative, you wait 8 to 10 weeks after the infectious contact was broken and repeat it. If it becomes positive, you treat for LTBI. If it remains negative, there was not a TB infection. Younger than 5 years, you still do those evaluations, you still do the testing, you still break infectious contact, but you initiate upon a negative TST IGRA presumptive LTBI treatment with either isoniazid or rifampin. Next slide, we'll talk about which for which. And then after the contact is broken, you repeat the testing 8 to 10 weeks later. If it's negative, you did not have a transmission event, you can stop. If it's positive, you're halfway through your LTBI treatment if you picked rifampin. When choosing window prophylaxis, I tend to use, again, a lot of rifampin because I just said that to you. It's a shorter duration. If we're waiting 8 weeks, we're halfway there anyway. But isoniazid is better and is preferred for anyone you're really worried about the risk of TB meningitis. So that is less than 1 year old, definitely, Less than 2 years old, probably. Um, and the trade off, though, is if you're wrong, you're setting up a longer duration of LTBI therapy. Now, two caveats here. The first is that a PPD is not accurate less than 6 months old. So I actually recently treated a TB exposed newborn. Um, Mom had active pulmonary tuberculosis that wasn't found until hospital day 3, and the child had roomed in. So that child got a full evaluation and started on isoniazid immediately. We did 6 months of isoniazid before we put the first PPD on because we didn't have an accurate PPD. And so 6 months is something that has to be remembered there. The other thing that I'll be honest with you that I do, if we're somewhere around, the 2-year-old mark, you have the dosings, and I put the size of the pills. You know, Sometimes it's just easier to pick one versus the other because the dose works out better. And that's also okay because I want it the easiest possible dosing for my families to really remove as many burdens as possible. Does this work? These are data from Houston, and yes, it works. But there's a couple of concerning things in there. So this is a large data set of children who were placed on window prophylaxis, 841 who were identified as exposures. First concerning thing, 10.6% never got window prophylaxis because by the time they were tested, they were already 8+ weeks out of exposure. So these were missed opportunities for window prophylaxis. We're lucky that these children didn't get sick. Of 752 who received window prophylaxis, they do a tremendous amount more of INH down there than we do here in New Jersey. Isoniazid is much less expensive than rifampin. There was no hepatotoxicity, but about 5% did convert. And the conversion was associated with a parental index case. That makes sense. You're closer contact to your parents. I think that makes sense. But the thing that jumped out at me that really concerned me here is it was not associated with being smear positive. And and that bothered me because there's a lot of times where I have been inappropriately feeling less concerned because the index case was smear negative. And that less concern is not borne out in data. So we're talking about index cases. What do we want to know about the index case? So I want to know how long the index case has been sick. Are they coughing? Do they have cavities? What's their sputum look like? Because how long is really the duration of exposure, the time under that exposure curve. I want to know when they started treatment. I need to know when we broke infectious contact. And then I really, really want to know about that source case's cultures, right? Look, is it confirmed MTB? Is there any resistance? And remember, we're living in a world now where we have PCRs. So I absolutely, you keep hearing me love rifampin. Is it rifampin susceptible? Because I certainly don't want to use a prophylaxis that isn't going to work because the bacterium is already resistant. So this is really the thing that's most, I would say, in flux. What do we use for contacts who have either, who are contacts or who have already developed LTBI, and the known contact source case has resistance? Um, the quinolones are really our workhorse here as long as they are susceptible. We are developing data in children for the newer drugs like bedaquiline, protamidid. That is almost done, almost out. But this is absolutely phone a friend territory. I would never evaluate one of these children without a lit search myself. And I strongly suggest, this is crowdsourcing. I'm talking to two or three friends, and saying, all right, here's this specific case. What would you do? Because the data are still, rapidly evolving. Because unfortunately, when we have these great drugs, we didn't necessarily test them in kids first. So as we're coming towards the end of the hour, I think we're okay on time. Um, if we were face to face, we'd be calling on people with raised hands. But just a couple of practices. If anybody wants to unmute, jump in, absolutely. If not, I'm in the interest of time, I'm just going to go through them, you know, moderately quickly. So let's imagine a happy, little 3-year-old without significant history, you know, normal birth history, goes to the pediatrician, growing, developing normally. Nobody's concerned about anything. And the preschool says you have to have a PPD because you just have to. Um, and it's 6 millimeters of induration. And now what? So first of all, is that even a positive test? Right? Because she's less than 4, so that should be less than 10 millimeters is positive. But I don't know what other risk factors she has. So we really need to think about, was there any contact? Where was she born? Has she traveled anywhere? There's a lot more history than I just gave you. But let's say you did want to evaluate her as a positive test. What are you going to do? So, symptoms. Does she have any symptoms? No, no symptoms. Does she have a normal physical? Yes, yes, she has a normal physical. Yes, I saw somebody popped up. Risk assessment, history of exposure, PE. Exactly. And then, if after all of that you believe this and you're thinking that that's a true positive test, then we need to initiate LTBI therapy. And, for a 3-year-old, I would say you can choose either of these. Now we've got a 3-year-old without a significant history, but with a parent who's been coughing for 4 weeks. And you get a call because their parents now admitted and has 3+ AFB on their smear in a right upper lobe cavity. What do you want to know from those people that are calling you? So I would say, I want to know, is this really tuberculosis? Did you get a PCR? Is there rifampin resistance? Do you have culture data? I really hope you don't. And I say that quasi facetiously because if you think about how long it takes for our culture data to come back, why did you wait this long to call? So I don't think we would have it back. But I also want to know, what is the risk of resistance? Has this person been treated for tuberculosis before? Are they some way connected to a country that has a very high prevalence of resistance? Because I don't know. I don't know if we need to worry about other drugs and resistance. And then the child, right? So we're here to take care of the child. We need to work them up. We need to do the symptom screening, the physical exam, the chest x-ray, and we're going to do an initial test. And there are 3, so we could do the blood test, the IGRA, or the PPD. And then we need to initiate the window prophylaxis, that visit. And assuming that it's rifampin sensitive, I would go with rifampin, because the thing is, I know that there isn't rifampin resistance, but isoniazid is also a possibility. And then we're making a plan to repeat that testing after contact is broken. If negative, stop the treatment. If positive, continue to complete a full course of therapy. And remember that INH has always been 9 months, but there are more and more expert consensus data that 6 months is probably good enough. So, thank you for listening and any questions?